Thank you very much. Well, good afternoon, everyone. As Deidre said, my name's Garrett. I'm doctoral candidate in the Philosophy and Religious Studies department, and also next fall a visiting instructor at the Department of Religious Studies. So I'm really happy to be here with you all today. It's my understanding that this whole course has really been based around health disparities and various factors that are related to health disparities. So what we're really looking at today is one really emerging factor that is becoming increasingly more significant as our culture becomes even more globalized than it already is. So specifically, we're looking at religion and health disparities. And I want to just kind of briefly lay out where we're going today to give you a bit of a sense of what to expect. And then we can talk about each one of the specifics a little bit, and we'll end with a group activity as well, which is actually not on this objectives list, but I think you might find it pretty interesting. So first, what we're going to do is we're going to just very briefly try to get a sense of what people generally mean when they use the term religion. A tricky thing to do, but we'll take a shot at it. The next thing we're going to really look at is what are the kind of most common dimensions that are sort of discussed in this discourse about religion and health disparities research. And then also what we're going to do is we're going to try to really apply a lot of this information in one particular group, a minority group here in America specifically. And I'll tell you why we're going to focus very specifically on one group in one particular region next when we talk about the tricky sort of nature of really kind of defining religion. So when you talk about defining religion, it is inherently, as I've said a couple of times now, a difficult thing to do. And the reason that's the case is there's a lot of contradictory definitions out there today. The way you can kind of understand this is every researcher who's talking about religion is motivated to sort of examine particular components and has certain aims, by which they're understanding the term religion, right? So an anthropologist may be more interested in the symbolic components of religion, right? Where perhaps a scholar from a different field may be more interested in the personal beliefs component of a religious definition. A lot of times these definitions actually end up clashing and contradicting one another. So, without getting too much into the weeds about how difficult it is to really get at a precise definition of religion, for our purposes today, I want to keep it pretty basic and just let you know that typically what we mean by religion is the world religions. That would be, the things probably you've studied in a world religions course, right? Most commonly, there are the big five that tend to be discussed. Of course, there are plenty of other religions that are important and worth discussing as well. But typically, the ones that will be discussed the most and are most likely to be encountered in a healthcare scenario would be Hinduism, Buddhism, Judaism, Christianity, and Islam. Really, these five traditions are going to be representative of the majority of individuals' sort of faith positions today. So when we're talking about world religions, though, I have to sort of caution us against using this term because it is a little bit misleading. Something that really is becoming more and more apparent in the study of religion is that each major tradition that we're calling a world religion, right, can take on a really different form based on where it's practiced. Which is just to say that the way Hinduism is practiced, perhaps, in a particular part of India is so different sometimes than the way it's practiced here in the United States that it's almost misleading to refer to Hinduism, broadly speaking, in its world religion kind of characterization. So we have to be really careful. A lot of scholars are sort of implying that for public health professionals, it's important to not necessarily characterize world religions, but to really analyze the practice of a particular tradition in one culture, if that makes sense. right? So it means we really need to take a thoroughly contextualized look at the things that we're calling religions today. When we're talking about Islam, for example, it's really important that we're taking a contextualized look on, at, say, Islam as it's practiced in America, rather than Islam broadly speaking, if we really want to get a sense of the relevant health disparities, because that context is what's going to oftentimes lead to some of the unique disparities that perhaps Islam, as a minority faith position here in the States, would encounter that perhaps it wouldn't encounter elsewhere. Does that make sense? Any questions on that? Okay. So now that we've got the tricky business of religion down, or at least kind of qualified, let's talk just a little bit about the health disparities research. I don't want to boringly read this information off to you. Most of this is for the online class, so they can read along or sort of pause if necessary. I'm really just going to kind of talk about some of these things. So when you're talking about religion and health disparities research, really what we have to sort of pay attention to is the way it's become increasingly significant in the 21st century. So recently, for example, just since 2010, more than 90% of medical schools are talking about these issues, about religion and health disparities. If you back up to the mid-90s, there were only 16 out of 126 medical schools that offered a similar curriculum. So you can see how in less than 20 years, this research has just exploded. And for some obvious reasons, which we can kind of dive into, it's become increasingly relevant. So when you're talking about the sort of religion-associated differences, one scholar puts it this way. The scholar says, studying religion-associated differences in health outcomes would represent really a paradigm shift for traditional health disparities research, which is now focused on three factors, which I'm sure you all have covered, and rightfully so, in this class, right? Things like race, ethnicity, and socioeconomic status. These things are incredibly important, and I'm sure your instructor and other guest lecturers have really helped you to understand just how important these three factors are. But the case I want to make for you today is religion is a fourth important factor that really is deserving of its own study. It's not something, as this last quote says, that ought to be sort of collapsed into the study of one of these other factors, which is just to say that when we're studying religion, we can't comprehensively understand the sort of religion and health disparities by examining, say, religion by way of ethnicity, or doing these sort of generalizations that are characteristic of like a world religions kind of study of religion. So really the case that I want to make is that religion should not be collapsed into one of these three factors. But as this other author says, the complex relationship, the complex nature of religion, it needs to be analyzed alongside of these other factors and teased out in relation to these factors. So what are the components of this fourth factor that I'm proposing for study in our health disparities curriculum? You can generally break it down into four things. I've kind of ordered these in the way that they typically are presented the most in the research. So the four components are as follows. The first one is an analysis of really a clear link between certain positive health outcomes and some sort of what we might call like a religious disposition or adherence to some faith position. The second component is going to be really kind of wrestling with conceptual differences between how characteristically religious people understand health and how biomedical ethics or biomedical sciences might understand health here in the West. as we'll see, there's going to be some striking differences, and those differences often entail some implications with regard to certain disparities. The third component is really going to be an analysis of the ways that religious ethics inform standards of acceptable and unacceptable forms of both care and treatment options, which is just to say that certain religious positions not only take a stance on what's appropriate or inappropriate for means of treatment, but also certain dynamics even within the room between a patient and a doctor, right? So we'll talk about that a little bit as well. And then fourthly, the last component that we're going to cover is an analysis of really just the unfortunate effects of religious prejudice. And this is where a contextualized study of religion becomes very, very important. As we'll see in just a little bit in my case study on the American Muslim population, there are certain disparities, certain issues that population is facing here in America that are not being faced as much in other places around the world. So that's when really studying not just the practice, but also the experience of being a religious person in a particular region becomes really important. While it may be easy to have a certain faith position in one part of the world, as we'll see, it may carry some sort of health consequences, some anxieties in other parts of the world, unfortunately. But I do think there's some things that we can do about that, and we'll talk about that a little bit as well. So, analyzing a little bit more closely this first dimension, the link between religion and health. What's sort of the basis for this, right? Today, there's been some pushback, I should say, against this sort of claim. Some people seem to suggest that a lot of empirical studies aren't fully clear on the relationship or the clear link between religion and health. That being said, however, it does seem like an overwhelming number of empirical studies tend to support this idea that there is a correlation between positive health, both physical and psychological, as well as shorter hospital stays and physical health and things like this. So what's really interesting about this, as I say here on this slide, is we might tend to think that, say, maybe this holds if you're a Hindu, but maybe it doesn't hold if you're some other faith position, right? What's really interesting, though, is it seems like irrespective of the religious position that's being held, there tend to be some positive outcomes that are associated with simply having a sort of religious orientation. So, that's an important thing to note, that it's not just some particular traditions which offer certain positive health outcomes, but rather there's something about the religious experience that seems to lead to positive sort of health outcomes in general. So when we're talking about this, one thing I like to kind of ponder is, and I'll open this up to you all in just a minute, why is it the case, do you think, that having a religious sort of orientation tends to be correlated to positive health outcomes? I'll give you a couple ideas, but I'd love to hear from you all as well. A couple of the things that commonly come up in the classroom and when I speak with professionals in the healthcare industry are things like they notice the community support element of someone who is a religious person. Someone who's a religious person is often accompanied by a community of people that even goes beyond, simply family or extended relatives. Sometimes practitioners accompany them to the hospital and sort of are there to provide an additional layer of interpersonal love and support, right? Which is just important for the human experience of well-being. Another thing that a lot of people point to, I'm reminded of one of the greatest psychologists of the 20th century. Perhaps you've read his book. His name's Viktor Frankl, and he writes the landmark work, Man's Search for Meaning. In this book, he talks about how people who have a will to live can bear just about anyhow they're going to go about living, right? So this is just to say that for Frankl, there's this idea of a super meaning, or a meaning that transcends even our own preferences of what we like and what we dislike. And there's something about that religious experience that provides a transcendent sort of notion of meaning, which is significant and gives individuals hope and a sense of purpose in their lives, right? So these sort of things I suggest, and a lot of research suggests, generally tend to positively impact overall health. Of course, we could probably think of a number of other things, and I wonder if there are any other ideas that you all might have, perhaps about the connection between religion and health. Yeah?
You kind of find like a sense of peace, like basically kind of going off what you said, because they have a purpose in life, they have a purpose to live for, so they have like a sense of peace, and so they might have less anxiety and stuff,
Right.
thinking about the future and stuff.
Right, great. So one of the suggestions was that there's a sense of peace that individuals who have a religious sort of orientation tend to have, right? And this sense of peace may be something that can combat certain mental health issues, such as anxiety, as you mentioned. That's a great example. And I see another hand back here, yeah?
I was going to propose you might feel more justified. Like if you feel as if you have God on your side or whoever on your side, or that you are morally in the right, it's easier to go through life, like you said, with a purpose. So you might be more justified in suffering. You might be more justified through like trials, like tribulations and things like that. So it eases that burden.
Right, right. So another thing that was mentioned is perhaps someone feels more justified in their experiences, and certainly individuals who have a religious disposition tend to think maybe this is some sort of a test, but through this test, their God, as they understand God in that tradition, is with them, right? And there's a sense of hope and a sort of drive to continue to carry on and to persist through that trial or that tribulation. That's a great point. Yeah.
I read this book, and it was about Buddhists in a small Thai community, and they have these cultural practices that are tied to Buddhism, and they have this practice called making the heart, which is basically just letting go of any anger, resentment, not holding on to basically not having strong emotions or emotional ties to anything. So when you have heartbreak or sadness and that stuff, it doesn't affect you as much as it would another person who grew up in another cultural background, where you, I guess, embrace your emotions more intensely.
Right.
That allows you to go through life without all, you being tethered to your emotions and that clouding your judgment. So you still obviously feel the same emotions as everyone else, but you just know how to, I guess, deal with it a different way.
Yeah, that's a really great point. So the point that was made is, by way of the example of the Buddhist tradition, their notion of detachment, right? And what's important about this notion is it gives people something similar to what maybe in the West we could kind of relate to a kind of cognitive behavioral therapy, if you're familiar with that, right? Where if there are certain sort of thought patterns that are creating anxiety because we're sort of holding on to anger in our lives, or we're holding on to some sort of thought that's not serving us but really is becoming a mental health sort of issue, then certain notions built into traditions, like the Buddhist notion of detachment, can really help to alleviate those things that may carry negative psychological consequences. That's a really great example. Any other thoughts on this? Yeah.
Faith is usually associated with strength,
Mm-hmm.
so direct linking the religion and health, the more faith you have yourself going through something and the people around you, the more strength you can have, or you can develop to help heal yourself. So more strength, more faith, more strength, more hope and mental health to be able to deal or get rid of the disability or whatever's debilitating you as a person.
Yeah, that's a great example. So faith, may provide something that, some individuals may find even more positive than positive psychology, because they believe it's not just something that they themselves are changing by thinking positively, but someone else is there with them through this experience, right? And that's another great point. This sort of positivity that someone's with them provides a sense of strength, which can and has been empirically shown to impact recovery times in many cases. It's pretty fascinating stuff. Really interesting. So those are some really great thoughts. I'm really glad you all mentioned those. I think those are really good additional things to consider. And I get the sense that you all have the first dimension down pat. You've got this pretty much down. So let's move on to the second dimension. This one's another kind of interesting dimension. It's going to take a little bit more thought work to tease this idea out. It's not as cut and dry as the first dimension of this analysis of religion and health disparities. So when we're talking about a religious orientation, we have to realize that such an orientation oftentimes has a very different view on health than we in the West and a sort of biomedical program may understand a view of health, right? So they don't people with religious orientation strictly don't understand health in medical terms. Simply put, I would say that many religions consider their health and wellness in a way that we in the West would refer to as more holistic, just a holistic view of the experience of recuperation and health care and treatment. So as part of this holistic view, individuals feel that they really need to have certain practices from their spiritual lives, which they bring with them into the clinics, the hospitals, physical therapy offices, what have you. These kinds of practices, such as meditation or prayer, for example, are things that they may feel distressed about if there's not an adequate space that's provided for them to basically enjoy these practices, participate in these practices while they're in a Western hospital. So this quote kind of helps to clear things up, generally speaking, and really provides a nice contrast between a religious view on health and a biomedical view. So I'll read it very briefly. It says, we're in a reductionist biomedical society in medicine sometimes, meaning that we think there's a disease that's causing everything. There's a physical problem, in other words, a medical issue, right? But religious individuals might feel that there's a relationship between their spiritual health and their physical health. So, as a consequence of this, they might resort to some spiritual guidance or therapies before or in conjunction with medical care. And as I've already mentioned, many of them may even see the experience that they're going through, which we in the West may refer to as a physical problem. They may see that in more spiritual terms as not just a physical problem, but also a spiritual trial. Right? So having a sense of empathy, for these patients who may be bringing, into the rooms more emotion than just, might be necessary regarding like the physical ailment they have is really important. For example, some individuals may come in with a sense of great distress that perhaps, as the way that karma works would have it, their physical ailment perhaps is a result of something that they've done wrong, which they may also feel guilty about, in addition to what other ways they're perhaps suffering, physically speaking. So as a way of kind of teasing this out a bit more, talking about maybe more specific components of a religious view on healthcare. We can generally sort of break this up across traditions into sort of three different ways of understanding a religious view on health. So we'll start with the third and work backwards because the third is closest to a biomedical understanding, right? So the third would be a malady of function. In other words, something that we would refer to as some sort of physically diagnosable ailment, right? So when we think of the word disease, this is usually in the West, in a hospital setting or a healthcare setting, this is usually what we're talking about. But for other individuals, they'll think a lot of times, if they have a religious orientation, that their malady of function is related to either a malady of disregard or a malady of imbalance or disintegration. So these things are not distinct in different ways that different religious people understand of health. Rather, they sort of see all of these things together, and they sort of see this as an interconnected web. The third might impact the second and the first, for example. Right? So perhaps someone's malady of function is a consequence of them disregarding some important aspect of their life, such as prayer, which is a significant component of many of the major traditions globally. And another way that we can sort of think about how they understand health crises is a kind of imbalance or disintegration that maybe isn't something that they've disregarded, but perhaps is something that they've more actively done, which they believe to be wrong or carry consequences. So we can think of like karmic implications here if we're thinking in the terms of Hinduism or something like this. So an imbalance in someone's life, perhaps an overly aggressive personality, they think creates certain natural consequences as well. In this life, perhaps those natural consequences will become manifest in a physical ailment. In the next life, perhaps, those natural consequences may result in them becoming a more angry species or aggressive species, like a tiger or something like this, for example. So these are three really interconnected ways of understanding health holistically that we can sort of generalizably speak about across the major traditions today. Are there any questions of clarification about this? Yeah.
Can you say, for this dimension, like the measles outbreak in New York with the Jewish population and the vaccination, is that like an example of this, would you say?
Yeah, that's a really good question. The question was regarding the measles outbreak, which we've all received news about very recently, right, in New York. And yeah, say that one more time.
No, I said they don't believe that group doesn't believe.
Right. So particularly within Jewish culture, as I've mentioned, it's really important to consider not Jews globally, and not even Jews just in New York, but also differences between, say, like Orthodox Jews versus more progressive Jews, right? As is the case with most traditions today, anything that tends towards orthodoxy is going to be a bit more reserved in terms of what it will not allow in a healthcare setting. So I'm really glad you brought that up. It's going to actually become relevant here in the next dimension. So that's a really nice segue. Thank you for that. This next dimension is really kind of talking about ethics and how religious ethics specifically carry certain implications, or we might think certain do's and do nots for each tradition. So we've heard one example that's relevant for Orthodox Judaism regarding vaccination, right? Based on certain sort of dietary restrictions, such as like halal for the Jewish culture, this would be something that that perhaps leads them to not be able to accept certain vaccinations. So when we're talking about this third dimension, I really can't do justice to it in a day. Many of my other classes that I teach take just this third dimension, and we focus on particular traditions in particular regions, one class at a time. So there's so much that can be talked about here. I'm leaving a lot of it out. But these are really kind of the major components of this third dimension of how religious ethics carries certain implications for both care and treatment, generally speaking, across a lot of the traditions. Yeah?
Yeah, I kind of read like the first one, especially in the blood transfusion.
Mm-hmm.
It really has become a big issue because like the physicians have to, the parents are like, oh, we don't believe in that, but it's a life or, death situation. So like ethically, like the doctor, the physician has to decide what to do and what not to do, which can cause, technically, like if they're under 18, they can't, when it comes to life or death situation, they can force them not to do the blood transfusion because they can die.
Yeah.
So like that stuff, it like becomes such a big like debate. It's really
Correct.
a debate going back and forth.
Yeah, correct. So one thing that gets really dicey, as was mentioned in this first bullet point here regarding Jehovah's Witnesses' stance on blood transfusions is, as a healthcare professional, say, you all are public health, aspiring professionals, right? So say that you want to be a great hospital administrator or a hospital director. My favorite, I'm sure maybe you've watched the show, is Max Goodwin from NBC's recent show called New Amsterdam, about the public hospital in New York, right? So say you're Max Goodwin, and say there's a Jehovah's Witness family who comes in, and they have a child who's really in a life or death situation. And while there are certain ways to carry out what may be necessary to save this patient, those ways are not very common, and this particular hospital doesn't have a way of handling this issue apart from blood transfusions. So the reality is that this 13-year-old is going to die if he doesn't receive a blood transfusion. So what do you, as Max Goodwin, the virtuous director of the hospitals there at the NBC show, New Amsterdam, what do you do in this situation, right? These are real live situations that come up a lot, and they get dicey, and to be quite frank with you, they're handled differently in virtually every scenario that these kinds of things are encountered. I have friends in Atlanta who have been through this experience as nurses, and they have involved DFACs. And then I have other friends who are in the hospital world, and they've chosen not to involve DFACs. So it really is tough. It's dicey, and there's not really a settled way that these sort of issues are handled. So it gets tricky. Yeah.
What's DFACs?
Yeah. So essentially, if a couple decides that their 13-year-old, they don't want that 13-year-old to have a blood transfusion, really what would happen is that child services basically would get involved, and they would essentially force or mandate that this transfusion take place against the will of the parents. So, when we're talking about religion and health disparities, a lot of times what we really need to focus on is increasing sensitivity and empathy for positions that differ from our own. But every once in a while, we can't help but feel that perhaps there is some sort of moral conviction that we feel if we don't get involved in a scenario. So these questions become really tricky. Where's the line between respecting a patient's values and between getting involved and sort of answering to your own moral convictions? Mm-hmm.
I'm just gonna say personally, do you think it's pushing boundaries because that's your son or daughter? I feel like you should have the decision. I mean, even if it's not what society, it's your choice.
Right.
know.
Yeah, so the question was, like, is it really, pushing the line, so to speak, to involve child services or something like this in a case of life or death? I would say it really depends a lot on the case. There have been some cases where, individuals have been able to be saved by other modes of treatment that are not very common. But a lot of that depends on whether or not that patient is able to be transferred in a timely manner to a hospital which can accommodate, Jehovah's Witness stipulations regarding blood transfusion. While we're on the subject, the reason Jehovah's Witnesses have this stance is because they really believe that the blood is this sort of sacred life force. So because it's a sacred life force, running it through some sort of machine would be really kind of like a sacrilegious thing to do. So it's a really serious issue, and we have to realize it's not ideal if we do have to involve defects. Ultimately, it would probably be better for everyone if we could come up with a way that both their moral convictions are assuaged and the patient is treated. But sometimes, as reality would have it, that's just not possible, right? And that's when it gets really tricky. So that's one dimension, right? And blood transfusions kind of epitomizes that. But there are other practices as well that you can talk about here. Another example that you can talk about is skin grafts. I heard a horrifying story once of someone who was a part of a tradition that didn't necessarily think very highly of pigs. And this skin graft happened while this person was unconscious, and essentially this individual woke up and was now, in her mind, one and the same as the very animal which her culture, her tradition believes is not clean, right? So imagine what that might feel like if you're a part of a tradition that doesn't have a particularly high view of pigs, and now you've been skin grafted, and are part of a pig, so to speak. So these kind of things come up, right? And it really suggests the relevance of having a sort of religious literacy and getting a sense of, what the major, at least, do's and do nots are, which has resulted actually in a lot of hospitals. Florida Public Hospital and Advent Health, in partnership with Advent Health University, for example, has recently come out with a book that's just like this giant companion guide, and it's on one book is on every floor of every hospital, and you can basically turn to it for the major do's and do nots if you know that someone is of a particular religious disposition and are seeking a particular means of treatment. Books like this kind of help to get a sense of some things that certainly can be curtailed with just a little bit of information, right? But some other things that come up here are modesty clauses. The modesty issue is probably the biggest issue that's encountered, as at least 3 of the major traditions have very strong modesty clauses, right? I'm thinking of Hinduism, Judaism, and Islam. But even within other, denominations, say, of like Christianity or other sort of factions of a broader religious tradition, they may have more modest or conservative clauses as a part of, their religious orientation than the rest of that tradition. And as a result, then, that means that a lot of these individuals will seek same-gender care. So, for Jews, for example, even for an Orthodox Jew, shaking the hand of someone from the other gender may create a kind of moral conviction, unless that person is part of their direct family. So we have to kind of be aware of these things, and obviously, in certain situations, it becomes quite tough to accommodate the same gender care needs. So these issues are very delicate. We have to realize the potential for moral conviction in these scenarios and try to accommodate that as best as we can. One way that this is often accommodated, say, if a female examination needs to take place and there's one male doctor to do it, to involve a nurse or someone else so that it's not just a male doctor and female patient scenario behind a closed door. These are sort of ways that the modesty clause is perhaps not fully met, but at least the moral conviction is not as consequential for the patient, knowing that there's someone else in the room who can sort of make sure that everything is okay, so to speak. So, in addition to modesty clauses, another thing that's quite common has to do with stances regarding sobriety. So I'm thinking specifically about Buddhism, but also you can think of other faith traditions where this may become relevant, like for people who are very devout Mormons or for Muslims, for example. In these situations, a sobriety clause may be so serious that certain Western forms of medication are not permissible, particularly medications that are intended to alleviate great amounts of pain, right? So kind of related to the sobriety clause and the way that cognitive faculties might be disrupted, there are also strong beliefs regarding the diet and how certain foods may disrupt the body. So take, for example, Hinduism. One particular dietary restriction that some Hindus share is it has to do with a belief about onions and how onions may sort of cause us to become more susceptible to an angry way of behaving or something. So there are really particular foods that we cannot essentially include as part of a diet for certain traditions. You can think about this a little bit more generally than just Hindus can't have onions and other specifics like that, by really thinking about certain major dietary sort of beliefs. For Muslims, you have the halal, right? But for Jews, you have a kosher diet. Within the Torah, there's a stipulation about certain animals that are hooved and certain animals that are not hooved, and what this means in terms of cleanliness. And for Hindus, there's a lot of different food customs, at least 3 major different sort of diets that could be followed. A lot of people, generally speaking, say that Hindus are lacto-vegetarian. Not as common today, but still quite relevant. So, when you're working with these traditions, it becomes important to at least ask the question, and maybe push beyond just a simple, do you have any dietary restrictions, to ask a little bit farther, not just the way that perhaps certain things will affect their body, but certain beliefs that they have about food that they would like to have accommodated, right? Sometimes they may not, say this if you just ask, do you have dietary restrictions? Sometimes it's a bit more important to ask, do you have certain beliefs about food that you'd like for us to accommodate, right, in addition to just the way that certain foods affect your body. Any questions about this one? There's so much that we could talk about here, but these are just a few of the major things that come up. I would say the most major thing being modesty clauses. The second most major thing being certain dietary restrictions that impact medicine and food. And then thirdly, particular stances about medical interventions as well, like blood transfusions and stuff like this. Of course, we don't even get into all the stuff about stances on life and euthanasia and abortion, and all of these traditions have very strong stances on all of those things. So it becomes important to kind of get a sense of those things as well, which I guess you could kind of would fall broadly under this first point here in dimension number 3. Any other questions about this? Okay, so that brings us then to the 4th dimension, which is something I think we're really familiar with, but maybe we don't think about as much with regard to religion as we might with regard to ethnicity. And of course, sometimes these things are really linked together in important ways, but they also need to be understood distinctly, right? The way that religious prejudice may differ from ethnic prejudice is important. And when you're talking about prejudice, I think this is one of the most obvious dimensions of religion and health disparities discourse that supports the idea that we really have to analyze religions in particular regions and not just broadly construe them. For example, certain prejudices are faced by Muslims in America after 9/11 that are not faced, perhaps in other regions, right? So when we're thinking about this stuff, we really have to think about the ways that religious prejudice weighs on the religiously devout. This could lead to anxiety, can lead to depression and suicide. It's even been shown to lead to underweight births because of the sort of inner turmoil of not being accepted or being socially outcast. These things weigh on people in ways that they feel like, they're not welcome, or they're not a part of a community simply because they have a religious position that's different. So another way that this becomes important is actually in a medical setting, right? Obviously, I think we can all sort of imagine with the recent politics of our day how these kind of religious prejudice, how this religious prejudice stuff, rears its head still. But sometimes we don't really think about how this happens specifically within a hospital. It doesn't just happen by way of governmental claims or policymakers' claims that may entail some prejudice, but it also happens in the eyes of a doctor looking at a patient, right? Patients feel this. They know intuitively if they're emotionally intelligent enough, which many of them are, if they're accepted or if they're not, right? And a lot of times a sort of passive-aggressive behavior that the doctor may not even really fully be aware of. This could be a subconscious thing in many respects. But this passive-aggressive sort of behavior leads to a distrust, where the patient doesn't necessarily trust the doctor's analysis of a physical ailment, and the doctor doesn't particularly lean in to analyze what's going on with that patient like he would with patients of different religious orientations. So we have to really consider how passive-aggressive ways of behaving, even if they're subconscious, can create distrust and lead to anxieties and distress, which are really significant for the religion and health disparities. And this happens most commonly in the minority religious traditions. So wherever you have a minority religious tradition in whatever part of the world, this is likely to show up, unfortunately. So let's kind of take each one of these dimensions and let's apply it specifically, as I've suggested that we ought to do, to one particular group of faithful individuals in one particular region. This region is a bit broader, I'll admit, than I'm even comfortable with, but I think it's just about the best research out there that kind of tries to contextualize, this health and religion disparities discourse. So when we're looking at dimension number 1, which we talked about the strong link between religion and health, There's a self-reported sense that Muslims have of hope and meaning that their faith provides them with. Pretty clear. I have many Muslim friends. I'm sure many of you do as well. If you do, you've probably heard them say something like this before. It's a pretty common thing that's said, as with many other traditions, right? As for the second dimension, the way that Muslims understand, generally speaking, in America, as a result of empirical studies, we know that the way that Muslims typically understand health certainly does differ from our biomedical understanding of health here in the States. A lot of Muslims view their physical ailment as some sort of trial from God, as something with a sort of spiritually relevant dimension, and in order to fully overcome this trial, being treated is not enough by a doctor. They also would like to have the space to pray and the space to allow a practitioner from their own tradition to come in and to comfort them and to be with them, right? Which is just to say that, sometimes even our non-denominational chaplains here in the States tend to be oriented towards the Christian tradition in a way that might be more distressing than comforting for someone who is, of the Muslim faith. They would probably rather have an imam visit them than a Christian chaplain, for example. So in the same ways that we try to accommodate the religious needs of a patient, which is precisely the point of the chaplain, right? We have to realize that today, chaplaincy in our globalized world looks a lot more like many chaplains of many different traditions than just one universal chaplain who can kind of, accommodate people from all walks of life. So the third dimension that we talked about, how religious ethics informs the do's and do nots of a particular tradition. For Muslims, in America, three particular things seem to come up time and time again. And these are in order of the most common to the lesser common, but still very common. The first is gender concordant care, right? I mentioned same gender treatment. This is something that comes up very often in American hospital settings where Muslims experience a kind of distress because a woman is paired with a male doctor or a male patient is paired with a female doctor. And then the other component that comes up very much is their dietary restrictions, halal, and how that might impact the foods that they can sort of sustain themselves with in a hospital setting, or even perhaps the medications that they're willing to take. And finally, the prayer space. Having a space to be silent and to pray or to listen to the divine is as important for Muslims as, say, having a space to meditate and be silent would be for like Buddhists or someone like this. Foundational to their practice of holistic health and well-being is praying 5 times a day. So we have to have a space that's suitable, or at least build in a time where they're not going to be disrupted so that they don't experience a kind of disorder in their overall health as a result of not having that time to make those prayers. And finally, I've already hinted at dimension number 4 in the previous slide. But when we talk about certain ways that prejudice impacts health, what's really interesting to look at is the American Muslim reaction to 9/11. One of my professors, Dr. Adib Fahardi in the Religious Studies Department, mentioned how he felt after 9/11, born in Afghanistan, American raised, and after 9/11, he just noticed that as a Muslim man, people looked at him differently, right? And this was something that creates a lot of turmoil that was really a shared experience for the Muslim American population. And related to that is the sort of distrust that is often felt by Muslim women who are wearing hijab for purposes of modesty, right? Many individuals within a healthcare setting and just broadly, in American culture have said that, the hijab stands for something else other than modesty, and they sort of affix certain ideas onto these women, when in reality, many of them who I've instructed in my courses have said they just have a real strong sense of purity, and they want to be able to be seen as pure by others and to not be objectified. And the students that I've had in my courses have all said that no one made them wear it. It was a personal choice that they took, which I think is something you can admire if someone wants to be a modest person and not be objectified. That strikes me as something that we can respect. But this image of the hijab has been used to represent other things, unfortunately, which causes a kind of tension and creates issues for individuals who want to wear it as an expression of modesty other than anything else. So, any kind of questions about this case study? All right, perfect. Well, I'm not disappointed by that because I do have one group activity which I think we have maybe just enough time for. So this one is something that I'll read aloud, and then I'd like for us to discuss as a class. So I think the way this will work is once I read it, I'll read to you the questions for reflection, and you can just get an idea of the kinds of cases that we have to really consider when working with people of a particular religious faith in a Western hospital setting. So this is a case that some of my students and I use in another course that I teach called World Religions for Healthcare Professionals. We go through a couple of cases every week that are similar to this to just kind of both get a sense of what we might do in a situation like this, which is not uncommon, but also to really get in touch with the fact that these ways of resolving these kinds of disparities are not oftentimes black and white, and there's a kind of nuance that each one of you can provide, and the real challenge is going to be speaking up in your own settings, right? When you all are playing the role of Max Goodwin in your relevant hospital settings or something like this, right? So I'll read this to you and then we'll discuss it. It says, I work for a large public hospital in the state of New York. Earlier this week, while on call, I was notified that a Buddhist patient had been admitted to the ER. She was approximately 30 years of age and exhibited signs of intense pain in her left leg. The patient stated that she had slipped down a flight of stairs, and as x-rays would later indicate, the fall resulted in a fractured left femur. Being the anesthesiologist on call, I was one of the first ones to see her in the ER. As I approached her room, I could tell that she was in a great amount of pain. Her voice was cracking as she tried to speak through her tears to the nurse that was already in the room. Upon my arrival, the nurse introduced me to our patient as the anesthesiologist that had been assigned to her. The patient expressed to the nurse that on a scale of 1 to 10, her level of pain was a 10. Based on this information, the nurse told the patient that we would be giving her some medication to make the pain soon subside. Immediately upon hearing this, the patient exclaimed, I will not take any of your Western drugs. Truthfully, says the doctor, I wasn't sure what she meant by this. Don't most countries rely on pain medications for cases such as these? I thought to myself. It's been said that fracturing one's femur is one of the most painful bones to break in the body, and under normal conditions, any anesthesiologist wouldn't think twice about alleviating the pain with something like morphine or its equivalent. Nonetheless, I asked the patient what she meant by her comment, and she clarified that her tradition does not permit any form of intoxication, even if Westerners call it medicine. So some things to think about if you're the director of a hospital and your doctor comes to you and says, hey, I've got this case, what should I do about it? When dealing with Buddhist patients, should the anesthesiologist know that pain medication is usually considered inappropriate for treatment? What do you think? Should that be something that they're already informed of as part of their practice of anesthesiology? Yeah.
I think they should assume that all Buddhists are like steadfast Buddhists, though. It's like, they should know, but they should still be like, you know, if she's screaming or something like that, maybe she's gonna be like, you know, the one time, like, my gods won't get too mad. But they should know, but they should still ask the patient just in case that patient isn't like super deep into their faith.
You raise a really good point, which comes up a lot within the discourse. And the point was that you can't necessarily just assume that because the patient is a Buddhist that they're not going to take the pain medication. Religion is such that, you know, one may ascribe to many parts of their faith that's characteristic of Buddhism, the practice of Buddhism in America, but maybe not all of those components. So we have to make sure that even if we are aware of certain Buddhist dispositions, we still ask.
I think like you mentioned earlier, how Advent Health has like that book on each floor.
Yeah.
So maybe like looking at that book before he goes in for like a patient consult would help him be more aware of that.
Yeah, that's a great point.
That initial reaction, like I thought everyone does this.
Right, that's a great point. So I mentioned that my friends over at Advent Health University and Advent Health worked with Florida Hospital to come up with this book that's on every floor. Maybe there should be a book like this on every floor of every hospital, right? Maybe that would provide a kind of solution for someone to turn to get an idea of like, okay, well, what is appropriate in this situation, or why is this such a delicate issue? Yes?
My first thought is an anesthesiologist's first thought is not going to be, what's the religion of this patient? What can I give them? You can't see religion at most times. So the anesthesiologist is going to do what they know, is to offer what they can. But as a healthcare practitioner, I believe, and I think a lot of schools which train healthcare providers know that that is something they need to be teaching their students, because these are things that they will come up with, or that they will be faced with. So I don't think that's the chief thing they should be thinking about. I do think it's something they need to know, and then they also need to know how to act on that afterwards.
That's a great point. So on a day like religion and health disparities, it's a lot easier to think about the significance of religion in every scenario, right? We might think to ourselves, why wouldn't you think about that, right? But considering the realities of someone in a hospital room who has a broken femur and is so distressed that you can hear the agony from, you know, rooms on down, it's not likely that that's going to be the first question that goes through the anesthesiologist's mind. But as you mentioned, it's good at least for the anesthesiologist to know something perhaps about this. And a follow-up question that I'll make available to all of you is, the practice of anesthesiology today, should they be equipped in certain ways where perhaps they have something that they could offer that is not, as intoxicating or cognitively impairing for their Eastern patients? Yeah.
I feel like the first thing they should do is definitely like offer because when you're under a certain situation, the first thing you do is just automatically think of like the fastest recovery, or putting them on medicine to relieve the pain. But they should offer the Western medicine, but also maybe the hospital should have a substitution, without morphine and something natural.
Yeah.
I think under any situation, any doctors and physicians, they're gonna do the first thing they're supposed to do, offer pain medicine.
Yeah, you bring up a good point. So, in a Western hospital, it's to be expected that, Western pain medications, which tend to be cognitively impairing, are probably the first, kind of choice. But as you mentioned, it's becoming more important for individuals in various practices, such as anesthesiology, to have some kind of fallback option, right? To have something perhaps that's less cognitively impairing. This is becoming something that's really increasingly relevant as we continue to be more of a globalized country, right? Yeah.
I was going to press into the issue of intoxication. Like, I know in like some cultures, being completely out cold is just a no. So I would ask her, like, what aspects of intoxication is it that you're trying to avoid? Because I know, like, an anesthesiologist, like, they have tons of different options they can use. Maybe instead of using like a full anesthetic, they could use like a local anesthetic, like something that keeps her cognitively aware,
Right.
still is enough to like numb her pain, which is like her biggest problem.
Yeah.
Like other forms of drugs that could deal with her specific issue that she has with intoxication.
Yeah, that's a really great question of qualification, right? This idea of kind of pushing in on the, this question of what does it mean for you to be cognitively impaired? Within the holy texts, that Buddhists have, it doesn't say anything specifically about particular Western medications, right? It's not like they're listed off by name and dismissed. Really, certain stances are held as a result of a general belief about cognitive impairment. So if we can tease out what it means for that person to experience moral conviction as a result of feeling cognitively impaired, then perhaps other solutions that we might not have thought could work can work, which is an important thing to consider. So how about question number 2? It may be the case that this anesthesiologist, given his practice, has some particularly strong views about medicine that works and medicine that doesn't. Should he share those views? Yeah.
When it comes to views, I don't think so, only because obviously there's already like a difference in what he views and what how she views Western medicine. So instead of views, I would say that maybe he could like put his views into facts, because I'm sure a lot of his views are factual information. But it's also understanding that when he does that, because of her religion, she's really not gonna like want to sway from what she believes. But yeah, for views, I would say instead of like views, because that might come off as like anger her even more, just have factual information to provide to the patient.
Great. So as you mentioned, it's important to distinguish between facts, say like what a medication is known to potentially do to one's body and one's mind, versus opinions about what an anesthesiologist thinks in this situation. I saw a couple other hands over here. Yeah.
I mean, I agree, the physician cannot force his views on the patient, but like when she's in a lot of pain, the physician's like bound to, like, if he's not finding any alternative, that's like for her, like she's against intoxication, and if you're in such a setting where there's no alternative for like anti-intoxicating medication, I think that he would have to go with his views, because like he's like the patient's in pain and there's no other alternative, and he's bound to like obliged to help her. He cannot leave her in pain. So I feel like it depends on the situation where he would have to like go like force his views on the patient.
Okay, so one suggestion is, perhaps because of the moral responsibility of the anesthesiologist to alleviate the agonizing pain of the patient, if he is not able to offer something that she, her moral convictions will be totally assuaged by, maybe he still needs to, you're suggesting, to accommodate this patient by essentially making this patient take certain medicine that will alleviate the pain. Does anyone agree or disagree with that? Yeah.
Disagree because her personal beliefs, like if he has personal beliefs, he wouldn't want someone pushing their views and their wants and desires onto that patient. Like you can't force someone to take a medication that they're not willing to take. Another way to handle it would be offer them different solutions, or asking them what their belief would allow for them to take.
Okay, yeah, so some expression of a disagreement. If we flip this situation around, for example, how would the doctor feel if he was the one that was, having views that were not his own forced on him? So as you can see, and as is the purpose of this group activity, it's not black and white. It's really tricky. And based on the case in question, these issues can lead to differences in agreement, differences in opinion about perhaps what's right and what's wrong in a certain situation. Oftentimes, really contextualizing these group activities and asking those lean-in questions like, what does cognitive impairment mean to you, becomes really important to